Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Welcome back to the Sit and Stay podcast brought to you by RipsyTech. I am one of your hosts, RipsyTech Product Manager Parker Anderson, and as always, I am joined by RipsyTech founder and CEO, the amazing Tom Tarshis. Hello, Tom.
Parker, how are you, sir?
I am good. Happy to be here for, I believe this is our 31st episode of the podcast. Very exciting.
Yeah.
So for today's episode, we want to talk about a pretty big topic that I think most providers encounter at some point in their career, especially if they're a solo provider, and that is managing a wait list. That is when the demand is outgrowing the supply. So anything that you'd like to say on this before we dive in?
Yeah, it's a interesting topic, and understanding the pros and cons of having a wait list going all the way back to when we started 17 years ago and how it evolved over time has been interesting to see, and I think is something unique in mental health, and lots of little nuances and things to discuss around the topic. So yeah, looking forward to sharing some historical information and trying to throw some advice out there so people can make an informed decision about what they want to do about their own waitlist policy.
Yeah, so speaking about history, when you first started out, did you have a wait list? How did you hit a point where you were kind of at capacity? What did you do to handle the balance between the demand and the availability?
Yeah, so when you start off, and when I started off initially, it was essentially like a solo practice, and you get some insurance contracts, or if you're cash practice, you get your patients, and eventually your schedule fills up. You sort of decide, okay, I'm going to see 25 hours a week of patients, and if you're going to do therapy as well as maybe you're a prescriber, you figure out that balance. But if you're doing a pure therapy practice, you really only need 20. If you have 25 weekly patients, you're full after you have 25 patients. There's different weekly frequencies, so you usually need a little bit more. And even if you were doing something where you're a full just medication management practice, if you're doing 25 hours a week, 50 patients a week, even if you're seeing them once a month, it's still only, after 200 patients, you're going to be full, which sounds like a lot. But if you think about any place that you live and the demand for mental health services, there are that many people that need services there, and you will hit that number. And so I remember when we started, I think it took about 5 or 6 months before there was just no more room in the schedule. Mm-hmm. And then, as was logical at the time, I thought, okay, well, I'll start keeping a wait list. So when new people called or requested an appointment, it was said, we don't have any openings. Would you like to go on the wait list? And then I started creating an Excel wait list of patients waiting to be seen. And I'd sort of let people know, we're going to be hiring more staff, and then we're going to have more openings. And of course, and I think I've alluded to this on previous podcasts, one of my biggest business mistakes, or I shouldn't necessarily say biggest, but one of the mistakes that I learned from over the years was, I had been keeping this wait list for maybe 3 months, and there was like 100 names on the wait list. And then I hired a new provider to start. And even though I hired the provider at half-time, 20 hours a week, and I assumed, okay, well, there's all these people on the wait list, it'll be easy to fill their schedule. when I went back and started contacting the people on the wait list, it was very few of them who actually still wanted an appointment. And it was
Right.
more likely the people who had just gotten on the wait list in the past couple of weeks.
Right.
And I realized that, people who'd gotten on the wait list several months ago, and this is what it's like in mental health, either they or their kids were doing better, maybe not great, but they were doing better. And so then all of a sudden there wasn't an urgency for an appointment, or a lot of the families had done much worse and had to alternate treatment paths. And so it was sort of this realization that, it was very few people that had been on the wait list for more than a couple of weeks that actually were still interested in an appointment. Then that led to a problem for me because I didn't actually have the patience to fill my new provider's schedule for some time, for several months probably, but I had committed to paying them for a benefited part-time position.
Right.
So that was not a good business move. And, I certainly learned from that. And then that was my first exposure to, issues with starting and keeping a wait list.
So, yeah, I imagine when it comes to mental health, for some of these requests, there's, an immediacy or an urgency to kind of feel like, if I can't see this provider now, then maybe I should look for another provider. So, I think your story kind of speaks to that, in that they were requesting appointments. They were requesting to be put on the wait list, but after a certain amount of time, then, factors have changed and it's not really looking the same. What about, what about for cases that seemed more, urgent? Like, was there a, what did you do about that?
Yeah. So people who needed a more urgent appointment at the time, or things were more.
Yeah. Well, I guess I'm wondering, if I was to start a practice and I was to decide that I want to have a wait list, what's a good strategy for determining, I guess, which cases are so urgent that I need to see this person now, or send them resources to be seen somewhere else? I guess how much of that responsibility even falls to a provider?
That's a good question, and I think it's the. I always feel obligated if someone calls and leaves a message, or if an appointment request comes in where there's clearly a crisis situation or urgent situation, I will try to reach out to the family and let them know, like, hey, you can't wait for a standard outpatient appointment opening. I recommend you look into an intensive program, or you need to go to an urgent care, or you need to go see your pediatrician because we need to figure something out. Mm-hmm. In general, if you're in an outpatient private practice, you don't want to feel like you're in panic mode or have to urgently get in any a crisis or high intensity case. Doesn't necessarily mean that you should fight very hard to get them in quickly, because you want to match the level of care of treatment to the level of care that's needed.
Right.
And anyone there should really be no such thing as a emergency outpatient visit.
If it's so bad that it's an emergency, then outpatient is no longer the appropriate level of care.
Right.
That makes sense. All right. So to loop it back to kind of continuing from where we started, so you had this approach to, you had your wait list, you hired somebody, and, the people on the wait list weren't able to fill up that person's time. So I guess, taking that lesson in mind, how's your approach to managing a wait list changed over time?
Yeah, and there's another little component that's tied in, which was also initially when I started, we would schedule appointments out up to 3 months out. And then I started to realize that, at the further you scheduled an appointment out, the higher the no-show rate got.
Yep.
So both in managing the wait list and in planning, how far out should you schedule? I just jumping to the gun right now, we don't schedule more than 2 weeks out really for new intakes at this time, because the no-show rate, if you go past that, starts creeping up there. You could decrease that by making sure you take a deposit before the first appointment, and that encourages people to show up. And then with respect to wait list, there's a lot of, and it's interesting because we're back addressing this situation now with our nonprofit again. So the 3 providers, our schedules are really filled for the hours we have right now. There are always openings, though, as people get better or the frequency decreases. So now we're back to that issue of what should we do about a wait list? For our other clinics, it got so well, and we're gonna talk more about sort of more concretely about the pros and cons of having a wait list. I think we are going to start a little wait list, but we haven't decided exactly how we're going to do that yet. And I'll say that that's not 100% decided. So it may be we just don't have a wait list, and you need to call or check back in if there's availability, and that burden, we put that burden back on the patient or the caregiver. Or if we do have a wait list, there'll be very specific criteria and screening to see who actually is going to go on the wait list, to ensure that there's someone that is actually waiting for us and wants an appointment with us. And so that, yeah,
I'm glad you brought that up, because it made me think about, like at a certain point, a practice maybe has like a reputation. Maybe it's a large group practice that's known really well in the community, and somebody really wants to get in there. Or maybe it's a higher level of care. Maybe it's a program, like an intensive outpatient program, like we've done with some of your previous clinics. Maybe there's a wait list for something like that. It does seem like there's kind of different strategies for how to approach a wait list when you're at different, practice sizes. I guess like if you have a very well-known, practice that people in the community really want to be able to be seen at, then it might make sense for your wait list to have a wait list, or for the wait list to get a little bit longer because people might really want to get in, versus if you're kind of like a solo provider and it's like, well, the care I'm providing can also be provided by this other person. Please go see this other person. But I don't know if it's like a family who says, I really want to get into this great community supported practice. We're willing to wait. I just imagine that there's kind of different dynamics there. Any thoughts on that?
Yeah, no, and you bring up a good point, and there's a whole ethics discussion around this as well. So, for example, sometimes you get, should you prioritize families that have no care versus families that do have care with a provider, but are maybe not super happy, or they've heard about your reputation and want to switch to you. So then you've got, well, they do have some mental health care right now. Do they deserve a spot on the wait list? Or is the wait list just for people who have zero care? And then there can be the scenario where, well, they see that you're in network with their insurance, and they'd much rather be paying their $20 copay than X $100 per session. So even though they've already got care, what are you going to do about that family that wants to come because you're in network with their insurance, which is a very reasonable for a family to want to do that.
Right.
So there are all these kind of even potentially ethical decisions around who gets a spot on the wait list. And we did have a point in our old clinics where we had a wait list, and then within the wait list, we had a priority level for like low, medium, high. And so we had, one way to do a wait list is sort of first come, first serve if you're going to do it. And the other one is to kind of do it based on some sort of priority level. And I think for our priority level, it wasn't around is the situation dangerous or urgent. It was more around, here's someone with zero care right now. They're going to be in our most urgent spot to get into the clinic. Okay, here's someone with very good care, but they're paying cash instead, but they want to be a network. Well, that's going to be a lower situation. Here's someone with receiving care, but they're only receiving partial care and it's not very good care. They can't get in very often. Maybe that was mid-level. So we had all these sort of complexities that, ultimately that's for a very big business where you maybe have someone assigned to managing a wait list.
Right.
And I will say that ultimately when you do have a wait list, you're going to have you're creating an extra level of unhappy people in the community who need services for their kid. Because then you also have issues of, okay, here's a spot that's open. How long do you hold that open spot for someone on your wait list? Is it 24 hours and you call them and send an email? Is it 48 hours? Is it 72 hours? Do you hold a spot for a week, which is hard to do, but if you're planning your schedule out 3 weeks in advance, maybe regardless, whatever you set, you're going to have someone call you the day after you've given away their spot and say, hey, I heard I'm off the wait list. And then when you let them know that spot's gone, you've got an unhappy phone call you're dealing with. So I don't want to weight it to all the sort of cons or hassles of keeping a wait list, but I want people to be prepared for some of the intricacies you do have to deal with if you are keeping a wait list.
Yeah, so in that specific situation that you mentioned, I think, expectation management plays a large role in it. So if you are going to be having a wait list, how do you go about, setting realistic expectations with the people who are potentially trying to get in?
Yeah, no, well said. So I think, and this goes to where before you even set those expectations, you have to think long and hard about what suits your practice and what you're going to offer. There are, especially when you're in solo practice or your own boss, if you have a late cancellation or someone who doesn't make it, other than charging for a no-show fee, it is lost income for you. So a big positive to having a wait list is if a patient is sick on a given day and then you've got an open hour, you'd love to quickly be able to squeeze someone into that spot. So one of the things around expectation setting could be, you have your waitlist families kind of do a questionnaire, and it's, especially for kids where the first session is parent only, it's kind of, could you be ready with 4 hours notice to do your first parent session for a kid? Or just sort of knowing, are you interested in getting an appointment with less than 24 hours notice? And, are you able to make that appointment? So some sort of questions around how flexible is the patient's schedule to actually make a random time to get in. That can be very helpful to have like 5 people who are ready at any moment to take any appointment time to get in to see you. But then it's around, the expectations of, I don't really recommend giving people a week to decide if they want a spot. I think it needs to sort of be a, maybe 36-hour window so people have, one full day plus the number of hours, and the other day you let them know there's an opening to claim or reject, the next open appointment, and you have to be very clear about if here's the window you have to respond to take the appointment, and if you don't, it's going to go to the next person. And then deciding if, how long can someone be on the wait list? If you are on the wait list, but you refuse to take the first 3 openings that come, is 3 the number where then, okay, well, we're not going to let you stay on the wait list and just waiting for a convenient time when the demand is so high to get in. And so
go ahead.
Yeah, so it's sort of thinking about what you want to have, and then, as you said, clearly explain those expectations to the people who do go on a wait list.
Yeah, and then when it comes to seeing minor patients, most people work a typical 9 to 5 schedule, and minors are in school from 8 a.m. to 3 p.m. on average. How do you go about also kind of like managing? This might be kind of a separate topic for a different episode, but how do you go about kind of managing the you got somebody on the wait list, maybe they want to get in, but they only really want that 3 to 6 p.m. time slot, or I guess, do they have to kind of be willing to go that extra mile to be seen at a time where might not be convenient for their schedule? Yeah, any thoughts on that?
Yeah, no, great question. Yeah, so that's, there's sort of these coveted after school spots for providers who see kids, and most kids actually have an early release day now that opens it up maybe from 1 p.m. On a day given the week. You will have some kids with alternate schooling, non-typical schooling situations that may open other times. But yeah, if it's very true that if your schedule is actually full, and this is where, we try to block some standard intake times that are after school and some standard appointment times that stay open after schools for urgent situations, or for, if you're just fitting someone in once a month, it's easier. But it is unrealistic for someone to think that they're going to immediately get an after school spot if they're coming off the wait list to someone whose practice is full. Mm-hmm. It's sort of, if an after school spot reopens up, there's going to be someone else who's already being seen in the clinic that's going to be higher priority for that prime, for those prime hours. So you need to, let the family know, hey, you're going to need to pull your child out of school for the intake, and that's a couple of sessions or 1 session, and it's, in general, not a big deal to pull a kid out of school, especially to get engaged in mental health treatment. But that's a good gauge of how willing, if the parent's like, yes, no problem. If there's something that opens up, we'll grab them and bring them in for that 45-minute time spot. It's a good way to gauge the willingness and seriousness of the families to become patients in your clinic. And then it is really important that you manage the expectation around, here's what we can get started with treatment. Here's the times that are available. It's unlikely that you're going to get an after school time until, you've been in the practice a while, just given that things are already full and those times are filled. So we're going to have to be creative with finding spots.
That makes sense. So I guess for the final question here, I kind of want to rephrase it, because I think we've kind of touched on a lot of this already. But going back to your earlier story of when you brought somebody on for the first time and they were working at 20 hours, how do you determine what the right strategy is in that situation? I guess, like, what would you have done differently? What are you maybe thinking about doing now that you're kind of facing a similar type of situation? Do you prioritize referring people, or do you prioritize bringing in additional help? And at what Yeah, and through what strategy, I guess, do you bring in that additional help? Is it, maybe 10 hours instead of 20 hours? Is it as a contract? I'm there's a lot of different ways to mix and match it.
Yeah. No, and I think, the safest thing to do for the business is to bring people in where they're paid, quote, on an hourly rate. So like, whether as a W-2 or 1099 employee, you're just going to be paid for the work that you perform while you start. And then can be, okay, well, as soon as you have 8 patients a week, we can get you started as a, 25% time regular employee, and can have a strategy for ramp up along those lines. I think that then you're going to come to the issue though, where maybe you have someone you really want to bring into your practice, but they're really not thrilled about, well, if my schedule's not full, I don't get paid, or might need some sort of, extra guarantee around that wage because people need to pay their rent and their bills. And then you have to make that decision about, well, are you going to go for it and work really hard to try to make sure that their schedule is filled, or do you not have the capacity for that at this given time? And, ultimately the reality is even with unlimited demand into your practice, it probably takes 3 months for any new employee's schedule to be fully,
right,
to be at their desired productivity, even if you have hundreds of patients. So just a matter of getting intakes in and, having the right number of young adults or parents or, kids or forever how the schedule goes. You need to plan 3 months for someone to be up to full productivity. So if your company doesn't have the cushion for 3 months of pay if someone's not working, and it's gradual, right? Because by month 2, you're seeing more,
right,
and month 3 you might be close. But we used to know every new employee would cost us kind of 3 months' salary until they're actually breaking even, and you'll be more competitive as an employer, and you'll get a lot more employees as soon as you can bring people on at their full salary right away, knowing that their schedule won't be totally filled. But that's not something that as a solo practitioner, you can cover 3 months of someone's salary while they're getting that schedule up. So you need to look to paying them for work provided, or starting with 5 hours, then 10, then 15, and doing it gradually to help protect yourself business-wise.
Yeah, this kind of goes beyond what we can figure out right now. But yeah, I wonder if there's some kind of like master formula or algorithm to perfectly predict, how big your waitlist needs to be versus how many people you currently have employed, versus, how much money you've got to be able to pay somebody versus, just a number of different factors. It's an interesting thing to think about. Maybe one day we'll
and I think and I think, as we have some enhancements coming in RipsyTech for, automated intake schedule, I think we're going to get to the point where we can do a lot of interesting experiments where we sort of have, we can track for which patients that submit an appointment request form, but there's no openings, but want to be on a wait list. And then, putting in future start dates of employees and how far out do you allow people to schedule. And if you let them schedule it, but you're taking $100 deposit, so you know that they're going to show. I think there is some good research to do, and then use a little AI to analyze results. And each clinic probably has their own perfect timing for
right.
How to hire and do the scheduling, and for at what number of quote people on the waiting list, or is it at what number of requests that you're getting per month? Then are you ready to hire a new provider? So that will be interesting for us to explore.
Yeah, it just kind of goes to show what kinds of really cool problems that you can solve with really good data. Awesome.
That's right.
So before we move on, is there anything else that you'd like to cover on managing a waitlist?
Yeah, no, I mean, I think the main things for people are to consider is just having a wait list or not. On some level, it's easier to say, sorry, I'm full, check back in. And you're actually almost least likely to have upset clients if you do that. However, with a little rigor and attention, having a wait list of 10 or so clients who are ready to take that next available appointment can really help protect your salary and income and be a great, has a lot of pros as well.
Yeah. Well said. Okay, great. Okay, then as for mental health business moment this week, what are we looking at?
Yeah, what is our mental health business moment of the week? Well, and I think we mentioned that we had been waiting to hear back from one of our major insurers about a increase after being in network with them for a year, and they did get back to us.
Yes. One of the few happy turnouts from a mental health business moment. Yeah, sorry, go on.
Well, and this one's not super happy, but this one is sort of, you have your insurance company that reimburses you the least, and then they come back and they sort of offer you $10 more for different codes, which by itself doesn't sound like a lot of money, but because this is the lowest reimbursing insurance vendor, it maybe works out to like a 7 or 8% increase on your rates, which, for after a year to go up 7 or 8% on paper, that's a nice yearly increase.
Yeah, beats inflation.
So, yeah, so it's sort of writing back like, these rates are you're still at the bottom with these rates, but we recognize that it's an increase and we'll accept it. But ultimately, in the business moment, we're going to be closing off new patients to this insurance. So for the current patients that have the insurance, we'll be happy to get that extra $10 or $15 a session. But it's still not to the point where, it's very hard to accept a patient where you're getting reimbursed 40% less than all of the other patients you could accept with other insurances. So I think our plan is we'll say thank you and we'll take those rates, and it will help with the current patients we see there. But we will accept very limited new patients. And then next year, when it's another year in, we'll push for another rate increase. And it's just a frustrating, slow, long game to play. And
yeah, I imagine that, this is kind of the payer mix that you talk about of, how many, what's the percentage of patients that you're seeing with this insurance, and what's the contract that you have with that insurance, and that kind of having a good understanding of that is a good way to keep your revenue stable. So yeah, I wonder if there's any kind of waitlist relationship there.
Oh yeah, Parker, that's 100% true and correct, right? So if you, I think from a, and this ethics gets involved again. So on some level, right. I think it's cleaner to sort of say, hey, if you have this insurance, we're going to let all the people with this insurance know there's just no openings right now. But then you're going to restrict the new appointments to the insurances that pay better. The families that have one insurance versus the other all need help and services.
Right.
There is certainly an ethical discussion to be had over, well, we're only going to accept patients who have one of the better insurances. I think it is clean ethically to do that, to keep your clinic functional. But having sort of a consistent, regular philosophy around that, and we could do an in-depth podcast on payer mix and how to decide that. You just can't. The most ethical thing you can do is just set a policy and be consistent with it. So, you know, if it's 10% Medi-Cal, 10% insurance A, 20% B, 30% C and D, because those pay the best, then that should be your payer mix, and that's how you're going to operate your business. If some insurance you want to keep working with, but they just pay you too low, you just say, you know, thanks for the rates, we'll keep our current patients, and you just close off new intakes till they pay you better. Just be consistent and explain that, and then I think you're okay.
Yeah, and I think it gets back to making sure that you set realistic expectations with anybody who's potentially going to get put on a wait list, and then also being willing to provide them with the proper resources to find something if they need something sooner.
Very true.
All right, awesome. Another great episode on the books of the Sit and Stay podcast, brought to you by RipsyTech. If you have questions you'd like to submit to our audience Q&A, or you're interested in featuring as a guest on our show, send us an email at sitandstay@ripsytech.com. All right, Tom, it was great. See you later.
Thanks, Parker. See
Bye.
you soon.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at ripsytech.com.